Good evening, everybody, and good evening and good morning, depending on which part of the world you are in. Once again, Dr. Truptesh and myself, we take great pleasure in welcoming you all for this webinar series, which we call as East Meets West. As you all know, this is the fourth session of this webinar series in the last 1 year, and we have touched upon various topics of general interest and common interest for endoscopists all over the world. Today's topic is on esophageal dilatation, and we're going to be having 4 faculty all over the world who are renowned faculty joining us for this webinar. Few housekeeping rules before we begin today. You will have opportunity to put in your questions in the Q&A box. If you have any difficulty in your login or something of that sort, other administrative questions, you can put that in the chat box. But if you have any questions, put them in the question answer box, and we will be happy to take it up during the question answer session at the end of the discussion. So today we have faculty from the East represented by Dr. Krish Ragunath, who already, although he was in the West a few years ago, he's now come to the East part of the world. Welcome, Krish. Dr. Krish is the chief and a professor and head of the Department of Gastroenterology and Endoscopy at the Royal Perth Hospital. And Krish has been part of many of the guidelines and all these for the esophageal stricture group. And along with them, we have Professor Rakesh Kochhar, ex-head of department of the Postgraduate Institute of Medical Sciences at Chandigarh, India. And we have our Western colleagues, Dr. Peter Siersema, the editor-in-chief of endoscopy from Netherlands, and Professor Dr. Adler, the editor-in-chief for gastrointestinal endoscopy from Denver, USA.
So many editors.
So many editors, yeah.
I would say.
Yeah, but definitely one thing I would like to again reconfirm about this, that this webinar is basically designed for a practical approach. With everything that we try and do is basically clinically and case-oriented and practical approach. So we're not going to have too much of literature review. Do not worry that we have 2 editors on board today, so we'll have a lot of literature. Of course, we will have some relevant literature discussion, but mainly the topic today we are going to be discussing as to what to do when. And with that, I would like to hand over to Truptesh to say a few welcoming words, and then maybe we can start off with the session. Truptesh, over to you.
Thank you, Amol. And thank you all the renowned faculties to join this program. And just to add, Krish is also the associate editor of digestive endoscopy. So now we have 3 editors over here. But anyways, I welcome you for taking out this time on a Saturday. It's evening in the East. It's morning in the West. Thank you, Doug, for joining us this early as well. And not taking away any time, I would like to invite and open the platform to Dr. Krish Ragunath to start his presentation.
Thanks, Truptesh, and thanks, Amol. I guess you can all see my screen here.
Yes.
Thank you. Thanks for your kind introduction, Amol and Truptesh. Just one correction, I'm not head of the department here. I'm one of the gastroenterologists at the Royal Perth. Thank you. These are my disclosures. Now, coming into esophageal strictures, as you know, it is not an uncommon condition, especially as a general gastroenterologist. Almost everyone would be dealing with this in their routine clinical practice. And this is a good US study published a few years ago, looking into the overall incidence and prevalence, which is about, I would say, roughly around 100 per 100,000 population. So it's not an uncommon condition. And I think it's a very good topic to discuss today with a mix of gastroenterologists and trainees who have been logged in today. So the management options, what we have when we are dealing with strictures are, I think the go-to is always standard dilatation, either by a balloon or BUG. And then we step up to steroid injections when there is issues about response to simple dilatations. And then you go on to other treatments, which are like incisional therapy, stenting, self-dilation, and surgery is hardly performed these days. So I'm going to be focusing on the first two, which is dilation and injection. And the two important questions to ask when we are dealing with the stricture is this a simple stricture or is it a complex stricture? This typical simple ones are 1 to 2 centimeters long, not angulated, as you can see in this barium picture here. It is quite commonly seen in peptic stricture, Shatsky, or a web, or sometimes in post-endoscopic resection strictures. On the other hand, the one which you're seeing on the right is a complex stricture where it is quite long, narrow, and you can see the lumen is different sizes here. And these sort of strictures will need some specialist management. And quite commonly, this happens in caustic strictures or post surgery, or sometimes a widespread endoscopic resection or ESD. So these are the conditions where you will be seeing complex strictures like that. The next question is there reflux esophagitis? I'm sure in your clinical practice, you're seeing that when you're scoping a patient, if you see severe inflammation, the first thing you want to do is to heal them with a PPI. And when you go back, sometimes the stricture goes, and you would have treated them just with the course of PPI. I was trying to look into the literature to see if there was any published evidence, and I bumped across to this paper published in Gut exactly 30 years ago. This is by Monas Dakak, who are known quite well from the UK, from Hull, and John Bennett. So here they look into the correlation between dysphagia and the lumen of the esophagus, wherein all these patients had a barium solo, and then a questionnaire from the patients about the swallowing difficulty, and then they looked into the endoscopy features. And the final conclusion was that there was a good correlation with the esophagitis as well as the stricture diameter. So what it means is that it is just not the diameter alone of the stricture, it is also the presence and absence of the esophagitis. So it's important there to treat the esophagitis. Now, a little bit about the science and the physics behind it. The science about it is that these strictures are usually due to fibrosis and scarring in the submucosal wall and resulting in narrowing and shrinking of the esophageal wall. Dilatation generally disrupts this fibrosis and then allows it to reshape itself so that you get a bigger diameter, and then it settles down with a newer shape. The physics behind dilatation is two things. One, how you are going to do it. If you're going to be doing it with a BUG, you have two different forces here. One is the axial force as you insert the BUG in, and the next one is the radial force as the BUG is stretching the stricture. So you've got two different forces acting here. Whereas in the balloon dilation, you only have the radial force, which exerts externally and dilates the lumen. So you will be thinking that since BUG has both radial and axial expansion, that will be better. But if you look into the literature, it is not the case. So here I've shown this cartoon where I meant this is the axial force and the radial force, and here is just only the radial force. And if you look into the published literature, basically, this is a recent systematic review, but there have been quite a few randomized trials or comparative trials showing that there's not been a big advantage, either you use a BUG or balloon. But my take in this is that there are lots of these studies in this meta-analysis have been quite a high heterogeneity. And in clinical practice, it is not always the same. For example, if you're having short, simple stricture, something like this, where you can see the other side of the lumen very well. It's sort of a Schatzky ring above hydrocenia. You can simply go and dilate it with a balloon and it will work. But if you see a stricture like this, which is in a patient with eosinophilic esophagitis, the lumen is narrow and unequally narrowed throughout the esophagus. And here, having a balloon is not going to make a big difference here, because you might be needing to balloon dilate it at different levels, which is not ideal. And I would straight away go for a Bugy dilation if I'm seeing someone like this compared to someone like this. So you need to really have a look into it, have an assessment of it, and then decide which will be the right thing for you to do. And essentially, it's horses for courses. Now, what should be your aim to how much you want to dilate is something you need to think about when we are starting to plan their management. Anything less than 5 millimeters, patient's not going to have anything much to eat, and you need to try and get it gradually up. And you need to go up to at least 15 millimeters to have a decent diet, and 18 would be fine for them to swallow a normal diet. So this is an average diameters and what patient can swallow. And this is something which you need to take into account when you plan your dilatations. Now, this is a video of Savary-Gilliard Bugy dilation. This was taken in Nottingham when I was there. You can see the unit there with the nurses, and it comes in different diameters, I think from 5, 6, 7, 8, and so on. And you normally insert, I would prefer to normally insert the stiff guide wire, the Puster wire. And this is a tight peptic stricture in a patient. And you can see how this was done under IV sedation. And you can see the wire in. We don't normally always use fluoroscopy unless there is issue about the complexity of the stricture. This was not a very complex stricture, so this patient is getting it done without fluoro. And there's a gentle insertion here, and always important to feel if there's any resistance. And you will normally get a give once it goes past the stricture. And then we will normally leave it for 20 to 30 seconds. And then gently remove the Bugy. So when we are doing this, it's important to ensure that there is enough tension in the wire so that it doesn't buckle. And also when you're inserting it, there is a reasonable tension so that it doesn't get buckled up when it is inserted in the oropharynx. And it's important it has a smooth sort of insertion. Now, as we remove the Bugy here, it's important to look and see whether there is any excessive blood on the Bugy, because if you are seeing excessive blood, then you need to be very careful, and it's always important to have a relook to see what was the effect of the dilation before going in for the second one. And this is quite a typical dilation, what you're seeing. There has been a few mucosal tears there, and then you can decide whether you want to go step 1, 2, and 3. This is the rule of 3, where you would normally go 1 millimeter above and then another millimeter above. This has also been questioned by a study. I think Peter did that study, but we can discuss about it in Q&A. But generally, it's a thumb of rule that you would normally go 3 dilations. This is another video taken in our unit, and this is my colleague here, Dr. Niroshan Mohanvela, demonstrating a technique where you put in a clamp once you get it close there, and then you insert, and then what you do is you take the clamp off and then insert the Bugy here. When you're doing it, put the clamp on the other end of the Bugy so that it's a safety measure. You know that exactly how much you're inserting, how much you are taking it back. Now you will see that the Bugy comes back until about the clamp, and then the clamp will be taken from here and then inserted on the other side so that the wire stays exactly at the same place and you know how much you've gone in and out. I think this is a very good technique people can use. This is something which is standard in our unit at Royal Perth now. Now let us talk about balloon dilators. Balloon dilators are otherwise called the CRE, or controlled radial expansion, wherein you can use a balloon. It will go up to minimum 3 sizes, like for example 10, 11, and 12, or 12, 13, and 14, so on. And it is done in such a way that it has got a controlled expansion, so you can decide how much you want to inflate it, and depending on how you feel the stricture is dilating. And a few things, technical tips here, how you do it. Generally, these balloons come length about 4 to 5 centimeters. So it's important for you to know the length of the balloon so that you know how much you need to insert the balloon through, because you need to have the center part of the stricture, as in here, in the middle of the balloon. So that you can do it by calculating the length of the balloon, which is roughly about 5 centimeters. And here you can see the proximal portion here. Normally there is a colored tip. This is the Cook one, where there's a blue one. In the Boston one, you'll have the purple one. It depends on whatever dilator you're using, so that you calculate the distance from here. Based on that, generally it will be about 1 to 2 centimeters, and then start inflating. Another important tip is when you're inflating, you need to make sure that this is pulled back close to the scope tip, so that it is a single unit when you are dilating it. Otherwise, it will tend to slip through or slip back. So it's important to do that and hold it tight. And now you can see through this, the balloon dilation, how the stricture is being dilated. So I'll show you this in a slide. So now it has been inserted, and it is pulled back in the right position, and you can see through the balloon here, and you can start to see, you can see in real time when the mucosal tear happens, and you can have here, once the balloon is deflated, then you can see the tears, and then you can decide whether you want to go one step more or not. It's always important to deflate, have a look before you go for the second step, so that there is a safety mechanism there. This is a short video of a patient who has a balloon dilatation. This is slightly unusual case. This is a patient who had a large EMR in a long segment of Barrett's esophagus. So I know this patient well. I know that there is this is a short stricture, and we electively bring the patient back within 1 or 2 weeks once you've done a large resection like this, so that he doesn't completely close up and get fibrosed when it becomes difficult to dilate. So when you're seeing like this, it's important to use the guide wire here, which is inserted through into the stricture there, and then gently insert the balloon over it. And there shouldn't be any resistance to it. And if you've known this case before, you've done that before, you know that there is nothing wrong here apart from that tight narrowing there that was due to your endoscopic resection a couple of weeks ago. So it is safe to go like that, and then put the balloon in and see the tip where it comes here, pull it back close to the scope. And then once you start inflating it, then you can start seeing it through the balloon, how the dilation is being done. And then here, I'm not going to be too ambitious here, not going to go to 2 or 3 steps here. I'm just trying to gently dilate it to keep the lumen going when the patient's on double dose PPI. That's it. So this is the only single dilation as a single unit, and railroaded the balloon along with the scope into the stomach. So this is one of the techniques what we can use, especially when you are doing dilations electively for after endoscopic resections. Now, how many dilations is needed? Most of the benign strictures will respond, 2/3 of them will respond in about 3 sessions, and maximum you will need 5 sessions, and 95% of them will respond. Now, the question comes, what happens if you've done that, if it doesn't respond? And that's where these definitions come in. These definitions are used in clinical trials and studies. So it is refractory or recurrent. Refractory is you're not able to maintain a diameter of minimum 14 millimeters if you keep dilating it every 2 weeks. So that is refractory stricture, where you're not able to get it above 14. Recurrent is you're able to get 14 or 15 millimeters diameter, but you're not able to sustain it because the patient comes back with the recurrent strictures after a month or 2. So that's a recurrent stricture. But you don't need to be too pedantic about it. So what you need to realize is that it is not a simple stricture, it's a complex stricture when you're not able to get a lumen above 14 millimeters after 2 weekly intervals of at least 4 or 5 sessions. Now, this is where you need to think what else can be done, and the standard practice, which many of us would do, is to inject triamcinolone or Kenalog injection to the stricture, which results in reducing the inflammatory response, also results in a reduction of the collagen formation, which is the cause for the fibrosis and the stricturing. If you look into the evidence behind it, there are not many published studies, but this is one study which I always quote from Mayo Clinic quite a number of years ago. It was a randomized trial, but unfortunately it was underpowered because I don't think the intended number of patients over 60 were recruited, but still there were enough patients to do the analysis, and it showed that the response was The recurrence was more with the placebo, with repeated dilatation compared to the steroids. And this is reasonable evidence to say that you can inject steroids for resistant refractory strictures. Generally, we tend to use about 80 milligrams of Kenalog in 4 quadrants in these patients. So this is again one of our videos Deroshan has done recently, in fact, about 3 days ago. And this is a patient who has a tight stricture proximal to Barrett's esophagus, and initially a balloon dilatation is being done. And once the dilatation is done, then the steroid is injected around the 4 quadrants post-dilation. And you can see the nice mucosal tear which has happened, and the steroid is injected just adjacent to it. So this is a technique which you can use when you're stuck with repeated dilatations. And majority of the cases, in my experience, it works. 2/3 of the patients will respond once they have done these dilations. Now, folks, I'll try and finish it in the next few slides. This is the UK guidelines on esophageal dilation, which I was part of, and Peter was also part of this, which was a multidisciplinary group who worked on the evidence-based guidelines. And this is a good, one of the recent guidelines, and you can look up for, which gives you a flow chart, what can be done, and evidence-based. So I would suggest it for further reading. So finally, in summary, esophageal strictures are not uncommon. It is almost every gastroenterologist will deal with in their practice. Ensure that esophagitis is treated first, and try to understand what is the etiology and the degree of complexity, because it determines how you would treat them. Dilation, either with balloon or bugey, is the mainstay, and you can step up to steroid injection if you are heating up towards a refractory stricture, which is second line. But more complex strictures will require specialist treatment, and we are going to be discussing these things in the next presentations. I'll leave you there, and thank you very much for your kind attention.
Thank you so much, Krish. I think it was a wonderful presentation, and you have really set the stage correctly for Peter to come in. So
Thanks,
we have Dr. Peter Siersema from Netherlands who will come up for the next presentation on esophageal strictures, cut or stent. So that is what Peter is going to focus on after Krish told us about dilate and inject. So over to you, Peter. Welcome. Look.
Thank you very much for this invitation. Of course, it's really a pleasure being here. I'm not in Rotterdam at the moment, but I'm in Beijing, and so I'm in the same time zone as Krish. So I'm not sure whether I'm from the east or from the west, but at least these slides were made in the west. So let me share my slides. I hope you can see them.
Yes,
So
we
this
can.
is my,
Yes, we can.
okay, thank you. So this is my hospital in Rotterdam. It's a brand new hospital, as you can see. It's in the center of Rotterdam, and it's a pleasure for me to work here on a daily basis. So the title of my talk is Benign Esophageal Strictures, Cut or Stent, and I'm just following up where Krish ended his talk. This is my conflict of interest statement. And this is actually the treatment algorithm that has been discussed in the previous slides. First step, always wire-guided bugey dilation or balloon dilation. And as a second step, dilation plus 4 quadrants steroid injections. And as another second step is incisional therapy. And incisional therapy is especially of interest in patients with anastomotic strictures. And the reason is that for these anastomotic strictures, patients do have a lot of fibrotic tissue around the anastomosis, and that makes incisional therapy very, very easy and also very safe. So this is these are some slides, and I also have a video following this. You can use a needle knife or an IT knife, and as I said, it is the preferred strictures are the anastomotic strictures. Here you see an anastomotic stricture, and then we start the incision in 4 quadrants, and that's what you see over here. And then you see that the stricture is nicely opening up, and this can also be combined with balloon dilation or bugey dilation, and that's what some people prefer to do. This is a video that I got from my friend Enrique Rodriguez from, sorry. I'm getting too fast, sorry for that. I got from my friend Enrique Rodriguez from Madrid. I think it's a very instructive video. Here you see the procedure again with a IT knife, and you can see it's really a very tight, narrow stricture. And as you can see, the incisions are being started here at the 7 o'clock position, and it is very safe because there's so much fibrotic tissue there, so that it's very difficult to make a perforation. So the next quadrant is being incised, as you can see, and there's already a nice opening up of the stricture. And we continue in this way, and then of course step by step. Don't be too much in a hurry, and take your time to make sure that you stay in the same plane, and that allows you also to open up this stricture, and that's being done over here. Finally, you see a further opening of the stricture, and this is well, it takes you about 10 minutes, and again, it is very safe because there is so much fibrotic tissue. In this case, there's an IT knife. Personally, I prefer to use a needle knife because I find it easier to use, and then it is in this case combined with balloon dilation. That's not always needed. I sometimes use it, but in most cases I don't use balloon dilation. I just incise and open the stricture in that way. So the second step, as I said, incisional therapy, or the third step, depending what you start with after dilation. And then if this is all not successful, and we prefer to perform at least 4 or 5 dilations, do 2 or 3 dilations with steroids, or do 2 or 3 incisional therapy sessions, and then we consider stent placement. And when we consider stent placement, there are 2 types of stents that can be placed: partially covered stents on the left side, or fully covered stents on the right side. And if you want to read a little bit more about these stents, I refer to the ESG guideline that was updated and published in 2021. You see the reference at the bottom of my slide. So the question is, of course, are we going to use for benign strictures a partially covered or fully covered stent? The partially covered stents have the advantage that the risk of migration is reduced because of the ingrowth of tissue at the top and sometimes at the bottom, but the risk of tissue ingrowth is increased because the stent is partially covered. At the same time, fully covered stents have a risk of migration, but the risk of tissue ingrowth is really reduced. For benign cases, of course, you have to consider all these aspects. When we use stents, you have to consider that if you place a stent across the GE junction, there's a risk of gastroesophageal reflux. But for the current types of stents, there's a very low risk of perforation and hemorrhage. For benign strictures, I would suggest to use a fully covered stent because it's easy to remove, and of course, it's sometimes quite complicated to remove a stent that has been embedded in the wall of the esophagus. So is there a typical stent that you should prefer for these type of patients? No, I don't think so. I think you can use any type of fully covered stent for this indication, 90S or Wallflex or Evolution, whatever you have. You should use a stent that you are familiar with, because from that stent you also know the characteristics, and I suggest to take that stent for these type of patients. What are the results? Well, the efficacy is 40 to 45%. So in almost half of patients, it's effective. Safety is an issue, of course. Stent migration, I explained it already. Tissue overgrowth in some cases, but there is always stent removal indicated. And this stent removal, of course, can be sometimes quite complicated. And there's always also a risk of recurrent stricture formation, and then it can be considered to place a second stent to treat these benign strictures. So how long should the stent stay in place? 4 weeks or 8 weeks maybe, or up to 3 months, up to 12 months. Well, this is our treatment algorithm. It depends in our hands on dilation history. So when we have a patient with a short dilation history, we leave the stent in place for 4 to 8 weeks. However, when we have a patient with a long dilation history, we leave the stent in place for 3 to 6 months. So, and that's basically what we're using in these type of patients. So we also have alternative stents. These are the biodegradable stents. They used to be very popular a couple of years ago. Here you see a patient on the left before with a stricture, then biodegradable stent was placed, and it's an uncovered biodegradable stent. And as you can see, the stent embeds in the wall of the esophagus. And here you see there's still some stent fragments in the wall. And this is after 6 months, and the stent has almost completely disappeared. And the degradation time of the stent also depends on the use of PPIs. In an alkaline environment, the stent degrades slower as compared to an acidic environment. So what are the pros and cons of using biodegradable stents? Well, the pros are, of course, that they absorb within 2 to 4 months, so you don't need to remove the stent. But there are also a couple of reasons why you should not remove biodegradable stents. There's a risk of hyperplastic tissue ingrowth, and it can be sometimes very dramatic. Some patients do complain about retrosternal pain, and that can be quite severe. And again, like with 19-hole stents, in 50-60% of patients, repeat stent placement is indicated. There's another alternative. Those are the LAMPS stents, the lumen opposing metal stents. They only can be used for strictures shorter than 15 millimeters. And this is an example from a paper that was published a couple of years ago. A short stricture, a lumen opposing metal stent was placed. It was removed, and this was the situation after removal of the stent at this site. So, coming back to this treatment algorithm, step 1, step 2, step 3. Is there also step 4, step 5? Yes, there is. Step 4 is self-dilation, mainly for proximal strictures. And when this is all not effective, you can also consider surgery. However, in our experience, we haven't had any patients that needed surgery for a benign esophageal stricture in the last 5 to 10 years. So what are the take-home messages? Mr. Chairman, dear colleagues, benign esophageal strictures are increasingly seen in daily clinical practice, and that's something you should be aware of. Stent placement should mainly be considered in highly refractory benign esophageal strictures, so it should not be a first step treatment in these cases. And finally, surgery is only very rarely needed in patients with a benign esophageal strictures. If you would like to read a little bit more about this, this is a topic about this. This is a paper about this topic, and I refer to this publication for more information. And finally, of course, if you have interesting information, we always are interested in interesting papers for our journal. The impact factor is 10.471, so it's even higher than stated here. And of course, we look forward to your submissions. Thank you very much again.
Thanks, Peter. That was a great and very precise presentation. Moving on, we are going to start the case discussion, and I would have Dr. Doug Adler present his case of eosinophilic esophagitis, and we'll open that discussion for a couple of minutes to the experts as well. So I would have Dr. Doug Adler take the platform.
Hi, everybody, and thanks for the invitation. I really appreciate being here. I'm going to talk about EOE today. And before I show the video, I just want to make some broad points about EOE strictures and their management. And you'll see some of this reflected in the video. Obviously, first things first, you always want to take a history on these patients, get a sense of how severe their dysphagia is, are they on medications, and how have they responded to those medications. It's often very, very tempting, and especially if you work with fellows, they'll put the upper scope in extremely quickly, and that's almost always a mistake in EOE, as many EOE patients have disease that's very proximal, and proximal disease is actually higher risk disease for an adverse event from treatment. I tend to do these procedures with a regular EGD scope. I only really use an ultra thin scope if I'm worried that I'm not going to be able to get through, or I'm going to need to place a wire. And in my experience, you almost never need to use a therapeutic channel EGD scope. It's really important when you're looking at patients with EOE. Oftentimes the esophagus can be very, very concerning looking, and there can be quite a lot of changes of EOE in the entire esophagus. But recognize that dilation is highly effective in this patient group, and about 90% of patients will respond clinically. The perforation rate to dilation in these patients is about 1%, so much higher than we're used to in a regular stricture, and about comparable to what we see in the setting of achalasia dilation. Early studies, and when I say early, I mean about 20 years ago, early studies showed a trend towards a higher rate of perforation, and that has really washed out over time as we have gotten a better sense of this disease and how to manage it. It's very, very likely, and I'll show this in the video, that you're going to see some pretty impressive mucosal tears if you do an EOE dilation. That is common, and that actually should not be reported in the documentation as an adverse event. That's actually to be expected, and it doesn't necessarily mean you did anything wrong, and it often predicts a better outcome on the patient's part. Recognize that you may find that you're doing your most aggressive dilation proximally, which is not where you usually think about doing dilations, and that the patient may have chest pain afterwards. It's very, very rare in my experience to have a true perforation in this setting, but of course it can happen. You can use Savory's or balloon dilators to treat patients with EOE. My personal preference is balloons, but it's not wrong, and it's within the standard of care to do either. I'm going to share my screen really quick, and then I'll just show you the video. Can you guys see that video?
Yes.
Okay, so this video is a little bit atypical in that it starts in the duodenum. So we'll back up, because obviously this is done with a regular scope. So you already know that the scope got through the esophagus to the stomach. And as we're sort of waking our way back, you'll notice immediately upon our entry into the esophagus that there are quite a lot of telltale signs of eosinophilic esophagitis. And this patient, just like we were talking about, even though this patient has panesophageal disease, the disease is worse proximally. So again, a higher risk situation. As a good rule of thumb, you don't want to dilate above 18 millimeters in most EOE patients. This is a 12-15 balloon. It's not an 18 balloon. And you can see already in that distal esophagus there's concentric rings, and it's obviously a narrow caliber esophagus. So here you can see the balloon is being insufflated, right? And you can do it like this, or you can do what I like to do, and you'll see in just a second where the balloon is pulled right up to the scope, and you can look right through the balloon, and you can watch the dilation in real time right through the balloon. I used to joke that way you could see the perforation happening in real time, but it actually, it's very, very helpful to do this. And here you can see we're looking right through the balloon. And this is really a staged pull through. So this is sort of a retrograde pull through in the esophagus. And you'll see in the mid and distal esophagus, there's a fair bit of room around this balloon. And as we get more proximal, it gets tight very quickly. And this patient's esophagus really tightens down proximally. Right below the upper esophageal sphincter is where the most prominent change is. And that doesn't look like that balloon is doing very much, but just stay with this video. Now you can see we're at about 25, 27 centimeters, and things are starting to get snug. And if you look at 6 o'clock, you can already see that a mucosal tear is forming. So the balloon is being let down just to take a look really quick and make sure we haven't done anything that we're too concerned about. You can see that mucosal tear at about 6 o'clock, but again, that is to be expected, and there's nothing really alarming there. The first time you start to do these, you will feel like your pulse is rising more than the patient's pulse, but that's okay. And here we are completing the proximal dilation. Again, just very gentle. And then when the balloon is removed from the scope, you'll see the full extent. And again, that did not look like a very aggressive dilation. but you can see this is a very substantial mucosal tear. You can see as we pull back, it's really on both sides. It's posterior and anterior. And again, this looks a little frightening, but there's nothing to transmural injury here. This is all mucosal. We're going to take the scope out and clean it for a second and then go back down and give you one other look at that. But again, that is desired. I really want to emphasize that. That is desired and that is not to be reported as a complication. You know, it's sort of like when Peter showed his needle knife of an anastomotic stricture. It looks pretty bad afterwards, but that's what you want. You want it to open up. And this patient may very well have some retrosternal chest pain, but this patient is going to have a significant improvement in their dysphagia. You can almost guarantee it. And again, a quick check just shows, again, mucosal injury and really nothing alarming for perforation here. I'll stop my share there. Okay. Thank you.
Thank you, Dr. Adler, for that wonderful case. And we'll have the questions at the end of, all the presentations. So may I request Dr. Kochhar to present his cases. Dr. Kochhar is going to, I think, present two cases, one on corrosive strictures and one on post-radiation strictures. And the PGI team, under the leadership of Dr. Kochhar, has probably one of the largest experiences on treatment of corrosive strictures. So over to you, Dr. Kochhar.
Yes. Can you see the slides?
Yes.
Yeah. Am I on?
Yes.
Yes, you are on. You can see your slides.
Okay.
Yeah.
Right. So I'll be presenting a couple of cases, starting with this patient of corrosive ingestion who had come to us after 72 hours of ingestion of an acidic toilet cleaner. 72 hours. He came with dysphagia, burning sensation, and hoarseness of voice. Had vitals were stable. He underwent an endoscopy. Okay. Yeah, he had hyperemia and erosions in the cricopharynx, confluent charring at scattered places in the esophagus as well as in the pyloroantral area. As a part of nutritional supplementation, he underwent a placement of a 12 French nasoduodenal tube, which we remove at 6 weeks when we do a contrast study, and it showed that there were 2 strictures in the esophagus and not too tight stricture at the pyloroantral area. He underwent 5 sessions of balloon dilatation of the esophageal stricture. The way it has been described earlier, the balloon is inflated for at least 1 minute, deflated, and again inflated for a second time. And you'll see that the second stricture is dilated when we pass the balloon down, and you see the fibrotic bands which are ruptured with each dilatation. He had 5 sessions of dilatation, but he continued to have dysphagia, though he had reached the level of 15 millimeters. So he underwent intralesional steroid injections, 80 milligrams in 4 quadrants, 3 sessions, and his stricture opened up and he became dysphagia free. However, as I had shown that he had a gastric outlet obstruction also, and he was simultaneously dilated with CRE balloons for this, and it required 6 dilatations to open up his pyloroantral area. Subsequently, he remained well, but had dysphagia again at 3 months. And since the last 2 years, he's on periodic dilation every 6 to 8 months, requiring 12 to 15 millimeters of dilation. So this case highlights that corrosive strictures are often complex. They may be associated with pyloric stenosis, and this case demonstrates that success is achieved with use of steroids combined with balloon dilation. Though he had recurrence, which is a common phenomena with corrosive strictures, which can be managed easily. So corrosive strictures can be long, tortuous, asymmetrical with variable sizes at different levels. So that makes it difficult to dilate. On top of that, there may be such intramural pseudodiverticula and seeming breaks in continuity. Then they could be supraglottic and cricopharyngeal stenosis, asymmetrical strictures. So most of these strictures need to be dilated under fluoroscopy. In addition, about a third of them have gastric stenosis, which also needs to be handled simultaneously. So the few questions which arise, when do you start dilation after corrosive ingestion? You have to wait for at least 6 weeks after ingestion before starting dilation. They are dilated as for other strictures every 1 to 2 weeks. Endpoint is 15 millimeters of dilation. Significant point is that 40 to 50% of corrosive strictures are refractory and about 60% are recurrent. So they need some kind of augmentation to their dilation, and that can be achieved with steroids or stent placement. A big question which has been raised in one of the earlier talks was, are balloons or bougies, which of these two is better? So the literature shows that both are equally effective. However, if you look at the number of caustic strictures in that meta-analysis which was presented, there were just 13 corrosive strictures out of those 300 odd patients. We have a large number of patients in whom we have looked at this aspect. 187, 122 underwent bougie, and 67 underwent CRE dilatation. And we found that the technical success, the short-term clinical success, and long-term clinical success was significantly better with bougies as compared to balloons. So with balloons, you have you dilate without getting the feel, whereas with bougies you stop when you feel that you have resistance. So because of that, our patients required more number of sessions with bougies to reach a diameter of 15 millimeters than with balloons. But the end result was that both the technical and the clinical success was better with bougies. So we prefer to use bougies unless you have multiple strictures or associated gastric stenosis. So can we predict the outcome of dilation in patients with corrosive strictures? Length and number of strictures do affect the outcome. Something more, possibly we have shown that use of mini probe EUS, you look at the wall thickness of the involved esophagus, compare it with the total esophageal wall thickness. If the proportion of thickness, the fibrosis is more than 70%, then you expect these strictures to respond poorly, and they are the ones who require some kind of additional augmentation. So overall, in our series, about 20% of corrosive strictures require surgery because about 10% of them are not fit for dilation because of too long strictures or having multiple strictures with malnutrition, they come late, and about 10% more strictures who fail to respond to endoscopic dilation. We do not, we have had not very good experience with self-expanding metal stents, so they end up having surgery. Intralesional steroids have worked wonders for most of our patients, and we were the ones who showed for the first time that they work. Intralesional steroids work in all kinds of strictures, with the least effective in radiation-induced strictures. So apart from that, once you start dilating corrosive strictures, which are 2 to 3 centimeters long, if they are difficult to dilate, you can augment that with needle knife, as has been shown, that you can do needle knife and simultaneously balloon dilate them. Self-bouginage is resorted to in a small percentage of patients who can be taught this. One rare, unusual case, this is 30 years ago, I had placed this Atkinson's tube in a patient of this multiple strictures who was not responding to conventional dilatation. And the stent is still in situ. He doesn't have any tissue overgrowth and he's free of symptom. So something to ponder for the stent manufacturers. So lastly, coming very briefly to a case of radiation-induced stricture, this lady with carcinoma tongue, 1999, underwent radiation and chemo, but presented 20 years later with dysphagia, has undergone multiple dilations, but still requires 1 or 2 dilations every 4 to 6 months. This is the kind of stricture which he comes with every about 6 months. So radiation strictures generally occur when you give a radiation of more than 60 grays, more common with lung cancer, but can also occur with head and neck. The overall success is about 73%, but recurrence is common in 65%, with the highest perforation rate for any kind of esophageal strictures. So you can do a retrograde and antegrade dilatation in those who have complete block of the esophagus, or recently you have the tunneling technique, which can also be used in some of these cases with a fair success. So to conclude, Mr. Chairman and ladies and gentlemen, corrosive strictures are difficult in about 30 to 40%, with overall response to endotherapy in about 80%. Adjunctive therapy or self-buginase is required in about 30% of all these patients, and surgery is used for failure of endoscopic therapy or for complications. Radiation strictures also respond to the tune of about 75%, and in patients with complete obstruction, you require a antegrade retrograde approach or the tunneling technique. Thank you for your patient hearing.
Thank you, Dr. Kochhar, for that wonderful overview and the cases. And I think we've had 4 fantastic presentations, which sets the stage for our Q&A session now. So let me begin by asking a question to Krish. So Krish, when you dilate using a balloon, a very practical point is that the guide wire that comes along with the balloon is usually pretty stiff. So do you use that guide wire, or do you use or replace it with a floppy tip wire? Because that is something that, sometimes can get tricky, because if it's an angulated stricture, that can happen. So any thoughts about that?
Amol, you mean to say the Pusto wires, the steel wires, what with a floppy tip, which comes
either a floppy tip or some other, even an ERCP kind of a wire, like a jack or something of that sort. Meaning,
and I tend to prefer to use the Pusto wires, which has got the spring tip. The reason is because it doesn't cause buckling, and it is easier for me to keep a straight angle as we get the balloon, the buging in. I don't tend to use the jag wire. Sometimes I tend to use it, but that's not the common wire I use. With the balloon, there is always a wire which comes with the balloon. I just use that, and I don't tend to use anything else when I'm using the balloon.
Okay, thank you. Because our experience is if the stricture is straight, then it's probably easy to get the wire through, but that wire is a little bit stiff, the one that comes with the balloon. And sometimes in an angulated stricture, it doesn't go across very easily, particularly if the stricture is at the G junction, because there might be a hiatal hernia below that, and then the wire kind of buckles and gets stuck in the hiatal hernia. And in that situation, you might have to use something else.
To add on, I tend to prefer bugey when there is any angulated strictures. I tend to use balloon only when there is a simple straightforward stricture. I can see the other side of the lumen, but otherwise I go for bugey. And if I go for bugey, then I use the Pusto wire, if not the jag wire. So I don't use the balloon when I'm dealing with anything which is angulated.
Right. Truptesh, you have the next question.
The next question is for Peter. when it comes to a complete closure, and we saw your video, fantastic video on it's just with the incision knife. And so the question is that how deep do we go and how many cuts do we make in order to open up that closed area? And is there any role of a bougie cap in such scenarios?
Well, maybe I should first start with answering this question, how deep you can go. And I like to stress again the fact that you need to be sure that there is enough fibrotic tissue around the stricture to make sure that you can do safely the incisions. And I think it's important to mention here that the needle should stay at the level of the esophagus. So you don't go any deeper than the level of the esophagus on top or at the bottom. So if you follow that rule, then it is almost impossible to make a perforation. And at least that's my experience. The second thing is that this bougie cap that's being marketed now, there's now a second version of this bougie cap. I've used the first version of the bougie cap. I was not very, let's say, very favorable of that using this bougie cap. The reason is that if you put it on the scope, it's a little bit difficult to advance a guide wire through it. At the same time, this tip of this bougie cap tends to go to the wall of the esophagus and then does not tend to follow the let's say the lumen. And so in my let's say experience, that may cause also a perforation. So I don't use this bougie cap anymore. But again, I haven't used the second version of this bougie cap because we addressed these issues with the manufacturer, and then they started to remanufacture the bougie cap.
Thank you.
Right. Thanks, Peter. Another question regarding the stents. So that is a question to Peter, but maybe others can opine as well if needed. You mentioned about the high migration range, the possibilities with the fully covered stents. Now, stent fix and stent fixation devices are now being evaluated, and there's a lot of discussion about that. So any personal experiences, any recommendations you would want to make regarding stent fixation when we're using a fully covered stent in these situations?
Well, in the majority of patients that do have a stricture, the stent is not migrating, so you don't need to fix the stent to the wall of the esophagus. The patients that are at risk of migration are the patients who have, for example, a perforation or only a minor stricture. Then there's a risk of migration. There are three ways to handle this, or maybe even four. I think one is, of course, to take a stent that is large, that has a large diameter. That also will reduce the risk of migration. The second is that you can also use just the normal endo clips that we are using, but then not use one, but use two and place them opposite of each other at the top of the stent. A third modality is, of course, suturing, but we do not have suturing in the Netherlands because it's just too expensive, and we do not have reimbursement for suturing. And the fourth is this new device that's made by Ovesco, the Stent Fix. And that's a tiny device, 80 millimeters, that can be used to fix the stent to the wall of the esophagus. And we have done quite a few cases now. And well, I'm quite positive about the reduction of migration that you see with this Stent Fix device.
Thank you. Thank you.
I have a question myself, which I encountered yesterday. I'd done a case basically for a squamous cell carcinoma, and I performed a hybrid APC half section, not the entire esophagus. It was from 12 to 6 o'clock position, and it was almost a 12 centimeter segment. And the reason I just did half segment is that there's a high recurrence rate of stricture formation in such patients. What I encountered that almost after 4 weeks, the patient comes to me with dysphagia, and then one of my partners, they did an endoscopy, found an ulcer at the G junction. So he or she just left it alone and PPI, BID, and then sent the patient back. Patient comes back tomorrow, unable to drink or eat anything. So I do a repeat endoscopy. I found an ulcer which is present, but better than before, than last week. So my question to the experts and also to the moderators, and also Amol, you can also chime in, is that when would be the right time when you see such ulcer to dilate this patient? What I did, I'll let you know afterwards, but I wanted your expert opinion before that.
So who wants to go first? Doug?
I mean, I would say that sometimes you have to dilate or stent when there is an ulcer. And if you wait for the ulcer to heal completely, you might be waiting forever. And we just faced this last week in a young man with a high-grade, benign appearing stricture with significant ulceration. He had been placed on high-dose PPI for 8 weeks. At 8 weeks, his ulcer was much improved, but still present. But he had about a 4 millimeter lumen for a 2 centimeter long stricture. And we did go ahead and placed an Endomax stent in him.
Okay.
At some point, you have to pull the trigger.
Okay.
Amol, can I comment on
Yeah,
that? Yeah.
Krish.
So basically, it is like any ablation, like post-RFA stricture for Barrett's or so. But my first question is, so this patient has had a squamous urinary neoplasia and had a APC?
Yeah, he had a hybrid APC. He is not a
Hybrid
surgeon.
Okay. But you didn't consider any resection?
No, it was a long segment. And with
Okay.
a Lugol stent, it was diffusely spread, almost
Okay.
12 centimeters from the G junction above.
Okay. So this would be treated like a post-RFA stricture. And if you get anything, I would gently dilate it within the first 2 or 3 weeks, because it's not uncommon to see strictures, which you can expect it, and you can electively bring the patient back for dilatation just to keep the lumen going, because once it gets completely fibrotic, then it becomes difficult. And then the question arises whether it is squamous high-grade dysplasia, it become a cancer, and all this mix-up comes in.
Okay. Dr. Kochhar, Peter, you have any comments on this?
Yes, I would also go for very careful dilation. At the same time, sometimes we consider to place a feeding tube in these patients, just to make sure that they have enough feeding in between. And we bring the patient back let's say every 5 to 7 days to continue dilation. I'm not particularly afraid of having an ulcer. As Doc already said, I mean, this is part of life sometimes. And you have to be, you need to be brave and just do it.
Right. Dr. Kochhar?
Yeah, I think exactly the way Peter has said. I would not be aggressive in dilation. I'll be, maybe 12 or maximum 12, 13.5, not dilate the whole fog.
Okay.
Just maintain the lumen.
Right. So, Truptesh, I think there are two issues here. One is the cause of the ulcer that needs to be assessed, and then how much to dilate is the next question. And I think, as everybody's mentioned, if the ulcer is the result of some ablative therapy or some kind of a resection therapy, then probably it is necessary to go ahead with the dilation as planned. Probably under dilate, as Dr. Kochhar rightly mentioned, don't be over aggressive in the dilation, but otherwise probably go ahead and dilate. But probably a similar kind of a situation in a peptic stricture with an active ulcer out there on the stricture, or sometimes even in a corrosive stricture and there is severe esophagitis around that, and in that kind of a situation, I would feel, that we may still need to dilate, no doubt about that, but I would really be very careful and really under dilate, just dilate as much as needed to maintain the nutrition, maybe put in also a tube feeding for this patient, and then probably wait for the ulcer to heal at least marginally until we become more aggressive with the dilation. So it has to be a tailored kind of a approach that we'll need to, figure out in these patients very often.
Right. So this is what I did yesterday. I saw the ulcer, and it was only at the G junction. It was not throughout the 12 centimeter. So again, the selection, that is, I selected balloon rather than initially I was thinking of using a bougie if it was a long stricture. But then when I went in, I just saw pinpoint stricture, not a pinpoint stricture, but a single A segment of G junction. So I dilated that, and the 9.9 millimeter standard gastroscope would not go through. So I dilated 8 to 10, just being on the safer side. And I'm bringing the patient back in 5 to 7 days, and he's on PPI BID. So that's my approach for this patient. And I agree with the experts. Thank you for making me feel better.
You sleep well tonight.
That is it. So
So
the
there's
next
one more
question.
Yeah, go ahead.
Yeah.
Amol.
No worries. You go ahead, and then I'll take the next
Yeah,
one.
so there was a question for Doug as well regarding EOE. When would you select the patient to get dilated? Is there a particular time, or you give the patients the usual steroid treatment first and make sure the EOE cells are less than 15 and then try to dilate? What would be your approach towards such patients?
Question. I mean, I generally try medical management first because in my experience, most patients will respond quite well to medical management. So I typically won't go to a dilation unless I feel like the patient has failed, or they're having repeated food impactions, or they're telling me that they feel like they're not making the progress that they want. I think, like a lot of people, our first line therapy is twice a day proton pump inhibitors, which in a Caucasian population is very, very effective, especially in males in my experience. And then if people fail that, we can move on to potentially a steroid. And then generally, at this point, you're now starting to select for the people who are going to fail medical therapy, right? If you're starting to think about elemental diets or 6 food elimination diets, right? These are now people who are essentially failing, and they're more likely to come to dilation. That video that I showed you is obviously a pretty impressive case of EOE. A lot of what we see is much less impressive than that.
Thank you.
All right. Thank you. So, Krish, what is the role of mitomycin and versus steroids? So, any preference of one over the other, and any kind of any thoughts on that?
It's a good question, Amol. The evidence for mitomycin is not much, and I think it's used mainly in children. So I've not personally used it, and the availability and the cost as well. So I'm not sure of any good quality randomized trials comparing them, showing superiority of mitomycin. So I'm afraid my experience with mitomycin is literally zero. So my go-to is steroids.
Can I make a comment there?
Yeah, of course.
There are a few retrospective studies on mitomycin for refractory benign esophageal strictures, and it is effective, but I will tell you that it's something that, like, you talk about a lot, but in practice, almost nobody does. I can't remember giving a mitomycin injection in over the last 10 years.
Right.
And
Thank
all
you.
the studies on it are old.
Right. So thank you. So the other
Amol,
question
may I?
was,
May I?
Yeah.
Yeah, Amol,
Yeah.
I'll just add to this that mitomycin, all the reports are using it with topical application, and that requires in children anesthesia, in adults an overtube. And secondly, the application is not controlled. You have a pledget dipped in mitomycin, you apply it to the stricture segment, and you do not know how much of the mitomycin is actually being applied. We tried giving it through injections. It is extremely toxic, irritant, and if you exceed more than 0.25 ml, it leads to ulceration and perforation. So it is something to be avoided in delivery if you are giving it by injection. Most of the literature is in pediatric age group using an under general anesthesia.
Yeah.
right. Thank you so much. And regarding the steroid injection, so should it be done before the dilation or after the dilation? Because this is a question where many, we just come up on the Q&A box, and there are 2 or 3 attendees who have asked this question. So,
Peter wants to go
what's your thought about that?
I
I
can,
think
I
it's,
can answer.
yeah, go on, Peter, go on.
No, please, it's your topic. So but maybe
No worries, Peter. It's everybody's topic. The topic is just esophageal strictures.
I'll just give my view on that. If you look into the study, that Mayo study, it says that injection first and then dilatation. But in clinical practice, I tend to dilate and then inject, because once you are dilated, then I feel that you're quite confident where you're going to inject it, rather than first injecting and then it forms a bleb and so on. And then dilatation can become a bit tricky. So, and I'm not sure much of evidence either way, but practically speaking, I would balloon dilate and then after that inject.
well, that's
Peter,
also
you have
my
something?
that's also my impression. When we did
Yeah,
a
I
study
agree.
in anastomotic strictures, we did an inquiry and asked several experts what they do. And actually, well, most people did it actually after dilation. And that's why we also decided to do it after dilation. And it makes sense what Krish says. If you dilate after injection, I think it may also lead to leakage of steroid out of the area of dilation. So the best way is to do it after the dilation, I think.
I think that that's actually the critical point, because if you do it after, the drug is going to stay.
Exactly. And the trick also, that's my impression, you need to inject very slowly. You need to have patience and don't do it too fast. So you do it slowly, and then you make sure that all the steroid is also inside the tissue and is not leaking out of the injection site.
Thank you. Yeah, and
Yes,
Peter, just
I have a point on that. See, it is probably better to use it after dilation. However, once you dilate a tight stricture, there's so much of trauma there. You cannot localize the exact site of location. So what we do is we wait for an hour or so for the immediate trauma and the bleeding to settle down, clean the area, and then inject after dilation.
That means you
However,
bring the patient back for a
yes, the patient waits for
after
that
about an
long.
hour.
Wow,
Yes.
that's
That could be-
different.
that could be challenging for most units, I believe, but that's really a very innovative thought. Meaning it's something that
No, it definitely makes sense, but in our workflow, that is really not possible. So we cannot do that. We have too many patients on the list to do this.
I think that's,
So
but
question-
that's really, yeah, Truptesh.
Yeah, there's a question for Dr. Kochhar, is that radiation-induced stricture, especially in the upper esophageal sphincter, UES, how do you manage those?
The radiation strictures are probably the most difficult to dilate, particularly at the upper end. A patient, for example, base of tongue malignancy, having radiation stricture. And second is patients with laryngectomy, developing radiation stricture where the whole respiratory passage is taken off, the vocal cords are off. So these patients require, number one, under vision and using fluoroscopy so that you are sure to pass a guide wire, a balloon through using a guide wire, wire guided balloon under fluoroscopy. And then some of these patients require very frequent dilation every week for about 6 to 8 weeks. And then they open up to some extent. And some of these patients have also been put on self-buginate because the stricture is very high up, and there is the angle of the neck is straightened in most of them because of radiation.
I would just say that, I think that the points you made they're absolutely critical. These are among the most difficult strictures, and you have to really commit to the patient, and the patient has to commit to the process. This is not something you're going to resolve in one stricture. And I would say 6 might even be a conservative number.
Right. So there's another question from one of the attendees that how do you choose between a bougie and a balloon? Now, this is a question that probably every endoscopist has because there's a lot of, and I think we'll have varied, opinions about each one of y'all as well. So let us hear it from each one of y'all. Maybe we start with Krish, then go to Peter, then maybe Doug, and then Dr. Kochhar. And Truptesh, you can chime in as well, definitely. I think.
Thanks, Amol. I said that in one slide. So my preference is that if it's a simple stricture and I can see the other side of the lumen, it's a short stricture, then I would go for balloon. If it is a complex stricture, it's a long stricture where there are multiple strictures, especially in EOE type of thing, then I would go for bougie. So and then I would use fluoroscopy as well if I'm doing something like that. That's my preference.
Right. Peter?
Yes, I have more or less the same schedule, I must say. When the stricture is very distal, then sometimes I tend to use a balloon. But for all the proximal strictures, I really prefer bougie. And the main reason that I prefer bougies in most cases is that I like to feel what I'm doing. And Doc, you pointed it out very nicely. I mean, it's not nice to see making a perforation. It's better to feel making a perforation, I would say.
I agree with the two of you, although in practice, I find myself as the years pass doing more and more balloons and less bougie. I think probably because I'm just trying to be more efficient and faster. Maybe I'm getting less patient as I get older. I don't know, but I definitely feel like I did a lot more savory dilation early in my career. And as time goes on, I have moved much more into the balloon camp, especially now in the era of EsoFlip, and we're using that device for a lot of our complex dilations as well.
Right. Dr. Kochhar?
Yeah, exactly the same. Maybe 10 years ago, we were using bougies very often, much more than balloons, but now balloons have found a better place. We reserve balloons for like the corrosive strictures, which are multiple, those with associated gastric outlets, gastric cicatrization, because a balloon is 5.5 centimeters, so you know how much is the length, and you go in, dilate each segment, go down, dilate the stomach. So when you have both esophageal and gastric cicatrization, you would prefer balloon. In children, you will prefer a balloon because they have small stomach. In patients with post-operative stomach, you'll use balloons. But given a choice for the same stricture, 3 centimeters in the esophagus, mid-esophagus, I would say a bougie will, and a difficult stricture in terms of corrosive, I will prefer a bougie over a balloon because our data has shown that the response is much better with bougies. You have the feel of dilating. You actually get that feel. With a balloon, you will have 8 to 10. There's nothing in between. You'll 8 and 10. So you don't get the feel of the dilatation.
Thank you. Truptesh, you can.
Yeah, no, I agree with them. There are a lot of questions, so I just want to jump to the next question. There has been a question that when you dilate, this is open to everybody. When you do a dilation and you happen to get a perforation in the esophagus, what is your management? Surgery is the last resort, but what would be your first line management, starting with antibiotics and all that stuff? So if you can throw some lights on that for the audience.
Well, for me, it's very simple in most cases, because, in most cases, I do have a guide wire already in place. So the first step in my case would be to place a stent.
I think Peter is exactly right here. And I think that it's just amazing how the thinking on this has evolved over the years. And I think probably all of us have had the experience of we're in room 2 and our colleague in room 3 or 4 calls us and says, hey, I was doing a dilation, I just perforated, I don't know what to do. And, if you're comfortable in the situation, it's really typically not difficult to move the patient to your room, put them on the fluoroscopy table, maybe take a look, possibly inject some dye or not, depending on how it looks, and then place a stent. And I will tell you, I actually often don't even affix the stent. I feel like our migration with some of the more modern stents is low enough that you can literally have the stent deployed within 3-4 minutes of taking a look. It's very, very efficient. And if there's no contamination of the mediastinum, the vast majority of these people will do extremely well.
Well, and maybe to add to that, I mean, you see the perforation, so there's no contamination. So it's an extremely safe procedure to do at that time. And you don't need to bother about contamination of the area around the esophagus.
That's my preference as well, Amol. The important thing is because there is a stricture, usually the stent will hold. It's not like you're doing an EMR for barrels or so. So there is already a stricture. So if you put in a fully covered stent, it will hold there as well. So I think that's the best sort of a modality to be used. People have tried clips and things. Usually, because of the stricture, it makes a bit of a mess around there, and the clip can go the other way, and things have gone wrong with clips migrating to the mediastinum and things. So the easiest and quickest thing to do is to insert a fully covered stent.
But there's another really important point that I just want to make here is a lot of times too, like you can admit these patients to the hospital and start them on antibiotics, but you don't necessarily need to call CT surgery, because sometimes that will just muddy the water and the surgeon will start ordering scans and things that you don't need, and they'll start writing stuff in the chart. And if you've seen the lesion and the perforation and they haven't, and you've sealed it and the patient looks good, sometimes, and we love our CT surgery colleagues, but sometimes your job is to keep them at bay and have them not do something that will be much more invasive and involved.
Exactly, and not only that. I mean, the issue is also if a surgeon sees air outside the esophagus, they immediately start talking about surgery. And of course, when there's a perforation, there is air outside on the outside of the esophagus. So don't make CT if not necessary.
100%.
So we give
A great
antibiotics.
learning point, I think. Yeah.
We give antibiotics. We place the patient NPO, place the stent, place the patient NPO for 24 hours. Next question is, when would you feed this patient?
And probably
Next day.
how is also how to.
When I want to be safe, I make a swallow, a barium swallow, or something with the contrast media swallow. But when I feel very comfortable that the stent has been placed perfectly, then I start with clear fluids and then expand on that.
We'll typically do a contrast injection at least at the time of the stent placement, and if that looks good, we can say clears the following day.
Yeah, it's also a possibility. Yeah.
Dr. Kochhar?
Yeah, if in doubt, I would place a nasogastric tube as well for feeding, as well as for allowing the stent to expand for the first 24 hours or so.
Yeah, I think that's a valid point. We would need to just wait for the stent to expand and then settle there and then start feeding. So I would normally put in a stent, leave it, get a contrast swallow, and make sure there's no leak before starting the patient on oral feeds.
Right. Patients with upper esophageal strictures, when they perforate, they usually tend to develop a lot of surgical emphysema and things like that. But these patients usually do much better than, those who perforate in the mid esophagus and the distal esophagus. Probably this has been my impression. And many of the upper esophageal strictures, when they perforate, you can get in a nasogastric tube. You usually don't need a stent and just conserve them for about 72 hours and they would seal off. I don't know what the impression of the other panel is, rest of the panel.
Fully agree. Upper esophageal sphincter or upper part of the esophagus perforation is well, relatively safe perforation.
Yeah,
So,
nasogastric tube and antibiotics and wait and watch is what I would normally do in these sort of situations.
Right.
There's no mediastinal or peritoneal contamination, so they behave much better.
Yeah.
Yes.
Right. So there's another question how stringently does one have to follow the rule of three? Now that's a, we've all learned about the rule of three, and that's a probably,
That's the interesting topic, and I'm sure Peter will mention about his study published in GIE a few years ago. There is not much of evidence because it's probably like something like a folklore that someone said that long time ago, and we keep following it, the rule of thumb. But having said that, you need to be safe than be sorry. And there is no point in being too aggressive and dilating it, aggressively. So having that generally keeps you under check of how much you are going to dilate, but not necessary that you need to just follow the rule strictly. So I would go by the etiology and what I'm trying to achieve by the dilatation more than just strictly blindly following the rule as such, because like one of the videos I showed, my aim was not going 3 steps. I just wanted to maintain the lumen post widespread endoscopic resection. All I wanted is a gentle dilatation, get the scope through and out. That's it, not more than that. So that's how we need to do that. But at the same time, the rule of thumb, rule of 3 is more of a safety measure for to generally follow.
I think the rule of 3 was made when we were using Adapusto dilators. It came at that. Those dilators were olives, very traumatic, 5, 7. So the sizes were like that, it was recommended that you don't use more than 3 olives. However, with savory dilators or with balloon dilators, for any balloon, you have 3 sizes, say 8 to 10 millimeters. You are already, having 3 diameters with 1 balloon. Same with savory, you have 7, 9, 11. So you will not jump from 7 to 11 in a very tight stricture. So it has become individualized rather than, following any rule. Plus, Peter's study showed that has no meaning today.
I agree.
All right, we are coming to the end of our session, and before I hand over the platform to Amol, I would like to thank all the faculties for joining us. And this was a very fruitful and informative session that we have had, and we had good presentations from the audience as well. So thank you, the audience as well, for joining us. And I will hand over to Amol for showcasing the next seminar that we have in 3 months from now.
Thank you, Truptesh, and thanks to all the 4 speakers. I think we had a wonderful discussion on esophageal strictures, and I think all of y'all who participated in this webinar definitely could take back quite a few learning points and take home messages as to how to manage your practice of esophageal strictures. We are thankful for sparing your time on a Saturday evening or morning for participating in this webinar. And I believe the success of this webinar series is of course, the faculty as well as the participants and the attendees who are so enthusiastic to ask so many questions. And invariably, we end up not answering or not taking up all the questions, but do not worry. All those questions will be answered before we close the meeting. And the entire meeting, the recording of the meeting will be showcased on, which will be uploaded on our free endoscopy YouTube channel. So in about a couple of weeks' time, we will have the meeting and today's webinar uploaded and the entire recording. And do subscribe to the channel so that you receive updates when the recording is available for you all to view. And with that kind of a this thing, it's important that we maintain this kind of webinar, this thing, because of the time zone differences. We know that although almost nearly 300 people registered for this webinar, not everybody attends at this point in time when the actual webinar is happening live. But the reason why they registered is because they can go back and they can attend this webinar once it is uploaded, and then that gives them an opportunity to hear everybody's views and then take it up from there. So that is how it is. With that, it brings me to the announcement of our next webinar, which will be on non-variceal upper GI bleed, and we will have 4 global speakers tell us about the art of endoscopic hemostasis. Professor Ian Grelnick and Dr. Alan Barkun from Israel and Canada, respectively, representing the East and the West. And we will have our moderators, Dr. Shannon Melissa Chan from Hong Kong and Dr. Rehan Haidri from UK. And mark your date. It's a Saturday, as always, August 26th, 2023. And the timing will be the same as today, 6:30 p.m. Indian Standard Time, 9 a.m. Eastern Standard Time. And of course, other parts of the world, y'all can make your calculations accordingly. So on behalf of the Foundation for Research and Education in Endoscopy, Free Foundation, we've been running this foundation for the last 10 years, and we've been associated with educational and research initiatives in the field of endoscopy. And we are happy to bring to you this webinar series, which has been so graciously supported by an academic grant from Boston Scientific. And we are thankful to Boston Scientific for their continued support in the field of academics and education. And with that, I would like to thank all the speakers once more and close this webinar. Thank you so much, and see you in August. Thank you. Bye-bye.
Thank you. Thank you.
so much.
Bye.
Thank you.
Have a nice Saturday.
Thank you, Amol.
See
Thank
the
you,
same.
Truptesh. Thank you, all
you.
colleagues, and it was great. Have a nice
Thanks,
day.
Peter.